Well, thank you, Robin. It's indeed a real privilege to be here this evening and to see all the great work that you all are doing and to really thank you for that. DSRIP is opportunity, and that's how I think of it. I'll tell you how our day started. We had a full staff meeting of the leadership in the Medicaid office, and the mood was rather somber because we all acknowledged that this has been kind of a tough week for our country with what's gone on in Orlando. And, you know, I think we're all feeling that. And so we acknowledged that, and we actually spent the first 15, 20 minutes talking about that, and then kind of conversation evolved into all the good work that is happening across the state and the good works that you are doing in your health networks and in primary care. We are all in this together, and if you don't succeed, then the state doesn't succeed. And so we need every performing provider system to be at their best, to problem solve all the challenges that we're all encountering. The state certainly doesn't have all the answers. And we look to you for helping to solve some of those challenges that we're facing in the day today. So you're doing really great work. We know in primary care, we are coming at you with many new transformation opportunities. And not only is there DSRIP for the Medicaid population, we have advanced primary care models for the state innovation model. We have the CPC Plus and MACRA that's coming for the Medicare population. So there's a lot. And on top of that, and built into that intrinsically, are value-based payments. So I'll spend a fair amount of time later in the conversation talking about VBP and trying to demystify both DSRIP as well as value-based payments. Additionally, Robin mentioned that I came really from a primary care background. I actually did a year of family medicine before switching to internal medicine, and I think that's where my love is and why I was attracted to infectious disease in particular, because you still dealt with the whole patient, and in HIV care, we got to do that. So we were the primary care providers for our patients as well as the specialty care providers for our patients, and we took care of them on the inpatient side and the outpatient side. We were the last holdout. It wasn't until I left that they turned our service over to a consult service. And the hospitalists now are managing our patients when they get admitted. But I feel like I have lived the benefits of what we envision with DSRIP through another funding source. We had grant funding through the Ryan White CARE Act. And those of you remember Ryan White, the hemophiliac from Kokomo, Indiana, who died of AIDS and was really shunned from his small community and had to move to Indianapolis with his mom and his sister. And in this model, and across the state really, the designated AIDS center models, we had integrated care. We had integrated behavioral health. We always had a psychiatrist on site seeing our patients, not always full-time, in fact, mostly not full-time. In the last 10 years, maybe 2 half-days a week. So we purchased, you know, the psychiatrist services from the Department of Psychiatry, sometimes not even from within the institution, sometimes from the community, to see our patients with our records and our charts in our space, and to be able to have those warm handoffs. It's very powerful, and it's very satisfying not only for the patient, but also for the provider. We had an LCSW. Sometimes we had 2, depending on the funding for that given year. The other piece that we had was, we were very fortunate, and we knew this, but we had care management services. We had on-site care managers. We had people who knew the resources in the community, so if someone needed inpatient or outpatient detox or rehabilitation, that they could help our patients get those services. But this came to be labeled in the latter years HIV exceptionalism. You had to have HIV in order to get these benefits. And I envisioned DSRIP really, and it's what enticed me to this position when I learned of it, is that really what DSRIP is trying to do is to put in those support services for the Medicaid member who has, you know, comorbid conditions, who has a substance use disorder, has depression, and, by the way, asthma or diabetes or hypertension or other chronic diseases. So that, in a nutshell, in my simple mind, is how I see DSRIP, is trying to put in place these support services that our patients need in order to be successful in navigating the healthcare system and keep them healthy and keep them out of the hospital and out of the emergency room. So I'll begin with, we'll talk a little bit about where the Medicaid redesign team efforts began back in 2010, and then we'll give an overview of the DSRIP program and try to help make that more understandable, and then we'll move into conversations about VBP. So in 2009, 2010, in New York State, the Medicaid program spending was really in double-digit increases annually, and it was increasing at a rate that was really not sustainable. And we were spending a lot of money, and we weren't getting very good health outcomes. And in fact, from the Commonwealth Fund 2009 report for Medicare members, we were 50th in the nation for avoidable hospital utilization. So there was a lot of work to be done. Governor Cuomo gets elected, brings in Jason Helgerson from Wisconsin to direct the Medicaid program, and he then led a Medicaid redesign team. And this team, including many, many stakeholders from across the state and many professional organizations, practitioners, community-based organizations, to come up with recommendations, hundreds of recommendations of ways to implement changes that would be smarter care delivered and could also result in cost savings. And then over the next 3 years, these efforts were really successful. And $17 billion were saved, and Centers for Medicare and Medicaid allowed New York State to reinvest $8 billion of those dollars back into our healthcare infrastructure to reform Medicaid and try to make further improvements. So it's kind of like the whole shared savings idea, kind of at a macro level. You have savings, and you then use part of those savings to reinvest back into your infrastructure. Of those $8 billion, there was an initial $6.4 billion designated for the DSRIP program, and then an additional $1 billion that we got over the past year, attributable to Jason's efforts with the legislature. And so there's a lot of money, but going for a very good purpose, and a lot of good work that we're doing and that you're doing. So in 2003, the average spend that New York was spending per Medicaid member was around $8,500 per person per year. If you take all the dollars spent and divided by all the Medicaid members, at that time was about 4.3 million members. But it was increasing, as you can see, and peaked in around 2009, 2010 at over $9,500 per person. These reforms started being initiated. Some of these reforms had to do with pharmacy and the ability to get rebates on drugs. Some of it had to do with moving the population into managed care, and many other reform efforts. And they started to fall in 2011, and by 2013 we're actually back to the 2003 levels. And by 2014 we're below the 2003 levels. So the goals of DSRIP are really to kind of remove the silos, and we're also working on that at the state level. We know that healthcare is siloed even at the state, in government, right? We have the Department of Health, we have the Office of Mental Health, and we have the Office of Alcoholism and Substance Abuse Services. We are all conversing now and working together in a very proactive way to break down these barriers, the regulatory barriers, the licensing barriers, all of those pieces. So all of that is work in progress. And to develop integrated delivery systems. So by that we mean both clinical integration as well as electronic integration, connectivity to your Regional Health Information Organization, your RIO, your qualified entity, and ultimately to the larger platform of the Statewide Health Information Network of New York. Within this integrated delivery system are where the patient-centered medical home, advanced primary care model projects also lie. Enhancing primary care, enhancing access and capacity for primary care, and I just learned tonight that you also have challenges around specialty care. So, you know, it varies by the region what the greatest needs are, but making sure that our members have access to primary care so that they can come to you and not have to go to the emergency room. And also expanding on and capitalizing all the excellent resources that are in our communities so that they can, their expertise can be brought to bear. And then I've already mentioned the integration of primary care and behavioral health, and we'll talk about the models that we envision for that. What I call the pillars or the principles of the DSRIP program are that we want it to be person-centered, that really to create a system that is more understandable for the member, for the patient, and to have a more coordinated care system for them. DSRIP is to be transparent. I was impressed coming from the community, coming from the provider world to the state, how much effort there is at stakeholder engagement. So we met with trade associations. We're always working with Greater New York. We're working with Haney's, Chicanes, all of the trade associations and provider organizations, MSNY, and all of the physician and nurse practitioner and PA organizations, and also with all of you to try to get input, because we don't have all the answers, and we're trying to all figure this out. We're all in it together. That it needs to be collaborative and working with our stakeholders, not just in the beginning, but as we roll along too, through the 5 years of the DSRIP program. but we also need to build in accountability within this system for providers, that we need to have it be performance-based, and we need to get value at the end of the day, and have a value-based system instead of one that's driven by volume. So in our current system, if you just think about it, what we reward in our health systems is sickness. We pay for people coming into hospitals and emergency rooms, and a readmission is reimbursed the same as a primary admission in Medicaid. And we really want to change that and shift those dollars and that spend to a smarter spend on the front end with preventive and primary care to keep people healthy and keep them out of the hospital and out of the ER. So this is just a slide to kind of talk about the continuity of the stakeholder process, that it's not just a one-time piece, but it is an ongoing effort. And it's not just provider organizations, it's not just clinics, but it's the entire health system network, including managed care, including our behavioral health providers, both in mental health and substance use, and bringing these worlds together. And our master at the state is CMS. So we work a lot with CMS, and we're now working through issues around shared space for integration. So we know that there are regulatory barriers, and so we're having conversations with CMS to try to break through some of those constraints around sharing co-located or integrated space for behavioral health and primary care in hospital extension clinics and in federally qualified health centers. So that's active work in progress. So each of the performing provider systems, the Care Compass Network is one out of 25 organizations across the state, but their projects were informed by a needs assessment. So each region was required to put together a needs assessment. What are the needs of our community? Where are the highest spends and the most dollars being spent on which conditions? Is it asthma that's driving our utilization? Is it diabetes? Is it substance use? Or a combination of those things? And that community needs assessment then helped inform the health networks, the performing provider systems, the PPSs, which projects out of a menu of 44 projects that they wanted to work on. And PPSs chose from 8 up to 11 projects to work on over the 5 years of the program. And they had this menu of, from a toolkit that really defined, with a page or two definition of what that project was about. And then build out an implementation plan that would really look out over the 5 years of the program to think about how we're going to do this transformation over the next 5 years. And then we'll have to meet and report out on both process and outcome milestones every quarter through the 5 years of DSRIP. And the partners here are the physicians, practices, as well as independent practices, the small and medium-sized practices, as well as hospitals, health homes, social service departments, your local health departments, as well as the behavioral health providers, skilled nursing facilities, and all that you see listed here are all of our partner organizations within the Care Compass Network, as well as the other performing provider systems. So the projects within DSRIP are organized into 4 domains. And domain 1 is really the organizational structure of the PPS. So it's the governance structure. There are committees on cultural competence and health literacy. There are committees on population health, on financial sustainability and thinking about the long-term piece and the budgeting of it, on provider engagement, performance reporting, and others. So the first year has been really about standing up the network, getting the network together, figuring out which providers and which organizations are going to be in the network, and how we're going to operate and how we're going to govern ourselves over the next 4 years of the program. And now we're really getting into the nuts and bolts of the projects and standing up the projects and working with provider organizations and provider practices to make this dream a reality. So the domain 2 projects are around system transformation. So this is where integrated delivery systems come in. This is where the patient-centered medical home, NCQA Level 3 2014 standards, or the advanced primary care through the State Innovation Model program, where these projects lie. So it's about clinical integration. It's also about electronic integration. And 22 out of the 25 health systems are actually doing an integrated delivery system project, and most of those who aren't, the other 3 that aren't, are doing something related to patient-centered medical home. The domain 3 projects are projects around chronic health conditions. So around cardiovascular disease, particularly hypertension, around diabetes, around asthma, around HIV as examples. The Domain 4 projects are different, and they're focused not just on the Medicaid members, but on the entire population of a region. So the population health projects are around mental health, smoking cessation as examples. So within Domain 2, you can see in the top left here, integrated delivery systems. 22 of the 25 PPSs, as I've said, are working on this particular project. 2 out of the other 3 are working on a related patient-centered medical home project, but everyone is working on integration at some level. These are projects that have been the most popular ones that have been chosen by the various PPSs. The next is the ED, Emergency Department Care Triage. This is connecting our Medicaid members who don't have providers in primary care to primary care services, and the requirement that they get hooked up and maintain that relationship with primary care. 2B4 is care transitions to reduce the 30-day readmission. So working around that care transition from the hospital to the skilled nursing facility or the hospital to your practices, and doing that better. And what can we do to make sure that you, when you're receiving the patient on the primary care side, have what you need to properly take care of that patient and know what happened in the hospital system. And instead of waiting on medical records, you'll be able to look into your regional health information organization or the Shiny and find those records and that information if you don't have them already at your fingertips. And then for project 2DI, this is our, what we call the 11th project around engaging those members who are not utilizing their Medicaid benefit services or are utilizing them inappropriately only through the emergency department, or those who aren't insured at all. So getting those folks engaged in care and in the healthcare cycle so that they're not accessing care for the first time through the emergency department. So those are our system transformation projects, some of the examples. In Domain 3, I've already mentioned the integration of behavioral health and primary care. There's 3 different models that the PPS has had to choose from. One is the model that I mentioned that we had in our own practice, where we had behavioral health, psychiatry and mental health, a social worker within our practice, embedded in the practice. Model 2 is it's the opposite, where you're putting a primary care provider in a behavioral health site, so in a mental health clinic or a substance use or methadone treatment center, so that they don't have to go somewhere else for their primary care. And then Model 3 is the impact model out of Washington State of collaborative care for depression. So using a depression care manager to help the physicians in the practices care for, diagnose, recognize, and treat depression in their practices as opposed to referring them out. 3BI is the project chronic disease management is around diabetes, the Million Hearts campaign, smoking cessation, and all that's related to that. Within Domain 4, the most popular projects were projects around strengthening the behavioral health, both mental health and substance use infrastructure, projects around smoking cessation, and a lot of activity and a lot of creativity going on around the state around smoking cessation. And then the other project around other chronic disease screenings and care, so for other projects that are not related to the Domain 3 project. So around COPD, around cancer screening, and cancer diagnosis. So what about primary care in DSRIP? So it is really a huge part of DSRIP. There are over 11,500 primary care providers committed within the DSRIP PPSs, over $400 million wrapped up in the Domain 2 and 3 quality projects. Everyone's working on integration and patient-centered medical home or advanced primary care, as I said, and on coordinated care and having care management services for those members who need those extra supports. Also, there is a regulatory oversight panel. It's called the Project Approval and Oversight Panel. And when the 25 PPSs presented to this panel in February of last year of 2015, the panel recommended and is requiring that each of the PPSs put together a primary care plan. And we just had a webinar last week that, as we've tried to design this program, thinking about what are the fundamentals to primary care. How do we make sure that the dollars are getting to the primary care practices and not just staying with the hospitals, and to help the PPSs think about that. So they will be responding in their mid-year assessment or midpoint assessment to their primary care approaches within each of their networks and what they're doing to address what we call the 6 fundamentals. So we'll move a little bit now to value-based payment. I think it was recognized early on that if we're going to be successful in transforming the healthcare system, we need to transform how we pay for it. And right now, we're incentivizing, inadvertently, kind of the wrong thing. We're incentivizing hospital and ER utilization when we want to be incenting primary and preventive outpatient care. So, value-based payments are really the structure to do that. So, it's an approach to reimbursement that rewards value. It's an approach to incentivize providers through the opportunities for shared savings, as well as shared financial risk for those who are prepared to do that. And we'll talk about what that is in a little more detail in a minute, because I know it's a little confusing and sometimes it just seems like fuzzy words. Also, tying payment to performance and to outcomes and to quality. So that's new, and there are incentive programs currently going on with managed care, but this is kind of a more wholesale look at outcome-based and performance-based payment systems. And then for VBP, it's really the sustainability component of DSRIP. DSRIP is a 5-year program. The funding will end, and VBP is how we're going to sustain these successes that we do in transforming the system over and beyond the 5 years of the DSRIP program. And by the end of year 5, there's a VBP roadmap that we've had to submit to CMS. It was approved for year 1. It's updated annually, and our second year update was just submitted to CMS for their review. But by the end of year 5, 80 to 90% of provider payment arrangements with managed care for the Medicaid population will need to be in some level of a VBP type of arrangement. And if we don't meet these goals, then the state won't realize all the dollars. We won't realize that total amount, and we'll all lose out on some opportunity. So there are different ways that the state is thinking about the Medicaid population. So on the left, what you have is really thinking about the model that people are probably familiar with, the ACO, Accountable Care Organization model. So it's kind of an all-in. So all the costs that are attributed to the health network are built into that system. So this is focusing on the entire population and all the costs. So it's a per member per month kind of capitated type of system. There are other arrangements that would count toward VBP, and one of the episodic bundles is the maternity bundle. So this is a bundle of care and payment structure that's based on claims that's triggered by a delivery. So a vaginal delivery or a C-section, and they look back up to 270 days, all the claims related to the pregnancy, and 60 days postpartum for the mom after leaving the hospital, and 30 days after for the infant. And so thinking about paying for the health care and the maternity care in that way, and incentivizing kind of improvements and ways to decrease C-section rates and ways to improve the quality of care. We'll talk a little bit more about integrated primary care in a moment, but it is another opportunity of a particular kind of chronic care bundle, if you will, that includes the preventive care as well as the routine sick care, as well as the chronic care of the conditions that have cost the Medicaid program the most over the past 10 years. So conditions like asthma and diabetes and hypertension, et cetera. And then there are specific populations that we know are high cost that could be carved out even out of a total cost of care type of arrangement. So those are the populations with HIV and AIDS. You need to have a population that you can easily target through claims data. So for HIV, the codes are V08 and 042. There's only 2 codes that we have to worry about to identify these through claims and encounter data. The managed long-term care population is another specific population that could be in or out of a total cost of care type of arrangement. Also, the HARP population, those with serious mental illness and substance use. So the HARPs are coming upstate in July of this year. So it's a managed care benefit product for those with serious mental illness and substance use. It stands for Health and Recovery Plan. That's what the HARP stands for. And then the population of those with intellectual developmental disabilities as a separate population. We know they're higher costs, and so those could be carved out of a total VBP type of arrangement. So this is just kind of a listing of what you just saw schematically, the total cost of care for the general population versus an integrated primary care chronic bundle, and what the actuarials and the experts in this field kind of tell us. And when we're thinking about primary care, it's about 40% of the costs of what would be in a total cost of care arrangement. So if someone has an automobile accident and you're in a primary care bundle, that would not be an expense that would be attributed to that primary care practice. Nor would cancer, because cancer is kind of like lightning. It strikes out of the blue. It can't be predicted, and it's not a routine, common primary care condition that is preventable. The idea is, and the word virtual, because I asked the very same thing. I just asked it last week. Why are we using the word virtual when it's really a budget? But it's a projection of based on the costs of care for, let's say, maternity, because I think it's easier to just think about a specific episodic type of bundle, and then it can be extrapolated. So you just think about all the claims that it would be related for the cost of care for having a baby for that mom. And we're also including in this 2 months postpartum for the mother and a month for the infant. And we can identify in claims what those events are and what those things that would be included in that kind of arrangement. So a motor vehicle accident would not be included, but a urinary tract infection or a hospitalization for vomiting would be included in that type of arrangement for that cost to be considered in that bundle for maternity care. So a managed care organization could contract with a health system or a hospital or an independent practice association for that care. They would base the rate that they're going to reimburse the practice on the historical cost of that data or cost of that care. And so you know what that cost is, and if a practice comes in at under that cost, then there are savings. There are dollars that could be saved. And how are we going to save those dollars? Well, if we're giving good care, we're preventing utilization of the emergency room and the hospital. So those are the downstream costs that are the high-end costs. And so in primary care, it's really about shoring up the primary care infrastructure so that our members, patients, can use the primary care practices instead of the emergency room for routine primary care services, because we know that they tend to overuse the ER right now. And some of that is patient education, and some of that is providers having access and the ability for patients to get access to them or to an urgent care center if the primary care practice is closed. The virtual budget is really kind of a proposed budget, what you're going to project for your costs for that upcoming year. And if there are, and we'll go through these kind of levels of arrangements. I think it'll be a little bit easier as kind of we dive into the VBP type of structure in this particular slide. So there's 3 different levels of value-based payments that we're thinking about for the Medicaid population. And levels 1 and 2 are really just built upon top of a standard fee-for-service model, a kind of pay for the services as we are currently delivering. Level 1 is no real risk to the practice. There's upside really activity only. There's no downside to it. It's the opportunity for shared savings. So if a practice or a hospital or a health network or a system decides that they want to go into this kind of an arrangement, if they come in under the budget of what the projected costs are for that particular year, for whatever population that they decide to work with, maybe it's for an HIV/AIDS population, maybe they're going to work on the maternity bundle or a primary care, integrated primary care bundle, if their costs come in under that budgeted amount, there are savings. In our current model, all those savings you don't realize. They're in a black hole. They're maintained by the insurer. They're not available to the provider. So in this arrangement, they could be shared 50-50 as an example. So that those savings, let's say there's $1 million of savings, we come in under budget. In our health network, there's $1 million of savings, $500,000 could be shared with the practice or the provider organization. $500,000 would go to the managed care instead of all of it going to managed care, to then reinvest to try to improve the services and raise the quality bar even further. So that's an example of an upside-only shared savings type of arrangement. There's no downside to the practice. There's only opportunity. For practices that have experience with this, and when they're ready, providers could move to a level 2. So in a level 2 type of arrangement, they're now taking on potential risk. So because they're willing to take on some risk and they feel mature enough as a practice or as an organization to be able to do that, and by say mature enough, I mean having had a lot of experience doing it. Montefiore has been doing VBP for about 10 years. And so they're ready at levels 2 and level 3 for some of their populations. So because you're willing to take on that risk, the shared savings arrangement, if there are savings to be shared, are higher. So it could be 90-10, that the practice is going to get 90% of the savings, the managed care organization only get 10% of the savings. But if there are losses, then the practice is going to be held accountable for that, and those losses would then need to be made up in the subsequent year. And all of this is contingent upon the certain quality outcomes and meeting certain quality metrics. So in order for the practice to be eligible for the shared savings, not only do there have to be savings that can be shared, right? We have to come in under budget, but there are quality metrics. So we need to meet at least 50% of the quality metrics that are laid out, that are arranged between the provider organization and the managed care organization. And that's a real basic and important component of value-based payments, is that quality comes into it, and it's quality that drives it, and the ability to be able to keep people healthy and keep them in our practices and out of the ER and avoiding some of those downstream costs are where those savings opportunities can lie. And then level 3 is the ACO type of model, kind of this all-in per member per month kind of capitated rate, where you're responsible for all the charges. You get a preset dollar amount per member per month that you contract with to take care of. And that's the model I think that people are more familiar with. That again takes a very sophisticated health system to be able to do that. It is the ACO type of model. So this is a slide that's kind of just meant to talk about the treating of the whole person. So in as much as we can do it in a co-located setting, one-stop shopping, it is, it's easiest for the person in terms of transportation, likelihood of getting to appointments, same-day appointments. We have worked out and are going to be implementing in July the ability to, for practices doing integrated services, to bill for both the behavioral health service as well as a physical health service on the same day under one claim. Before, one could not do that. We're still challenged with federally qualified health centers who are working under the prospective payment system to be able to do that, and that is a federal issue. It's not a state issue, but at least we're getting it on the radar of CMS to work on that. So that the service integration is really about kind of trying to take care of the entire person, and the more we can do it in an integrated, coordinated setting, probably the better it is for that person, and probably easier for the practices in some ways as well, if you have that system set up. In terms of what we expect, in terms of the benefits, the ability to communicate better between behavioral health providers and the medical providers, information sharing, understanding patients. Right now, even in our own electronic health system at Albany Medical Center, I can't see the notes of my patients when they go to the psychiatry unit, but I can see the notes of our patients, the ones that are seen in our own practice at our site. So it's a very helpful thing, and I got the psychiatrist right there that we can confer with and have that conversation. I can introduce the patient to the social worker, the care manager, or the psychiatrist if I need to in an acute situation. Hopefully there will be, the benefits that will come out of this will be, improved patient outcomes, improved patient satisfaction, improved provider satisfaction, and ultimately some economic gains if we're successful in this process. So I mentioned that I would come back to the integrated primary care piece, and there are 3 components to this, and it is the preventive care services that you see on the top left. So the well visits, the immunizations, and the things that would be considered preventive care. The chronic care conditions, these are the 14 conditions that are the highest prevalence conditions in the Medicaid population and also the highest cost to the population. And then the routine sick care for things that are primary care related. And this would include the hospitalizations for things like pneumonia and common conditions, but it would not include, for example, a motor vehicle accident or things that occurred as a result of cancer and all the diagnostics and the expensive care that goes into those kinds of diagnoses and conditions. So with that, I think that's what I plan to say this evening. There are going to be other speakers talking to you about some of the specific elements that they're working on within the Care Compass network, and then we'll have an opportunity afterwards for more questions. Or did you want to do questions specifically now? Okay, so we can do questions now. I'll be happy to take So the question relates to inadequate network for mental health services, behavioral health services, and it's a statewide problem. So we are certainly aware of this, and we know that some of the PPS networks are working on expanding that provider group, trying to think creatively about using social workers and other folks in practices to help psychiatric nurse practitioners. Another strategy is using telehealth and telepsychiatry. So particularly in rural areas to access specialty care like child psychiatry if areas don't have that access. And I know this is an issue in Watertown, and they're subcontracting with Syracuse where they have child psychiatry services and using that through telepsychiatry. So those are some of the ways, but it is certainly a goal of DSRIP to work on that. But we know that it is a workforce issue, that is a particular area that has high need and where there are real shortages across the state. There is an entire workforce effort, and there's a workforce committee and subcommittee that have been very active thinking about this problem, and it is one of the committees that's ongoing through the whole 5 years of DSRIP, 4 years left because we just ended year one, to try to improve and expand access to both behavioral health care as well as to primary care providers. Yeah, so the question is, how does our state compare to other states? Certainly, in terms of behavioral health, I think that is a national crisis in terms of having psychiatrists and enough behavioral health providers. I think everyone is feeling that. In terms of primary care, I think that's also a national challenge. It has, we need more primary care providers, and so we need to train more providers and try to entice people to stay into primary care and not go into specialty care or not just stay in hospitalist care. And so, but how do we compare? I think New York compares very well nationally. And in terms of DSRIP is a model that the entire country is looking at. There have been other DSRIPs across other states. And they have not all been successful. In Texas, the model wasn't so successful. They tried to take on too much. They took on too many projects. They had too many health entities, and it was just too big. And so, New York was able to benefit from some of the lessons learned from some of the other DSRIP activities in some of the other states. Not every state has DSRIP. A handful do, but I think New York is considered a leader and a thought leader in healthcare and healthcare transformation, and also even internationally. And I think right now Greg Allen and others in our program and Peggy are going on a listening tour around the state to hear some of these concerns that you're expressing, so that we make sure that we try to keep our finger on that pulse and do what we can and change what we can, and work with CMS and to try to address a lot of those things. There's also VBP boot camps, they're called. So going around the state between now and the end of the year to try to help providers and the PPSs and the networks within the organizations better understand the value-based payments infrastructure, so some basics around VBP, and then how to do the contracting, because this is all relatively new, and how does a provider organization that's not used to contracting with managed care go about doing that, and then also getting to the point about of just standing up and setting up these arrangements, and then thinking about piloting the arrangements. So over the next couple of years, 16 this year, 17 and 18, VBP pilots are being started across the states, both in downstate regions and in upstate, to try this out and to see what are the best practices and to learn from some of these models before kind of rolling it out. Everyone can participate if they want to, but right now it's still in kind of that learning phase, but it's going to be a fairly rapid ramp up of this transformation and the payment structure reforms. Yes, sir. So the question is the quality metrics that are going to be the metrics for these different arrangements. So each of the examples that I showed you, like the maternity bundle and chronic care bundles and so on, have had clinical advisory groups convening around that very issue. The outcome metrics haven't all been worked out, so nothing is laid in stone yet. So getting a lot of stakeholder input about what makes the most sense. So they're largely going to be around HEDIS measures, and QAR measures. These are the state measures, quality assurance reporting requirement measures, and some of them are just around screening, some are around prevention, some are around chronic care, Some of them are around potentially preventable visits, so around avoided ED visits and hospitalizations and readmissions. So depending on the arrangement that you're talking about, it could include any and all of those, but it wouldn't be, it's not the whole world. It has to be kind of relevant to that particular bundle that you're talking about and a select number of indicators and outcomes. Because we know that there are way too many measures, and you are measured to death, and every plan has their set of measures, right? And when I had to present to our hospital subcommittee for just our HIV quality thing, there were over 100 things we were supposed to be working on. And in some cases where people had the different measures, or they wanted the same measure reported, they had different numerators and denominators, different ways of calculating that same measure, so it made it a challenge. There's a whole lot of work and effort and attention going on to try to align measures, say with advanced primary care, also another state model, with DSRIP and with other activities and with managed care, because we hear this, and it's absolutely true that we have to align the measures so that they make some sense and can be manageable at a practice level. Yeah, so the licensure issues in terms of who can bill for what are determined by the Department of Education in terms of that licensure piece. So the Department of Health, and it is a little bit of passing the buck, and I apologize for that, but it is the way that our government is set up. So the Department of Education does the licensure piece, and then the Department of Health does the actual Medicaid payment pieces. And so in terms of who, I don't know that there will be a lot of movement in terms of the level of practitioner who can bill for this level of service or that level of service, but we are certainly working on the whole concept of shared space and what can be allowed. We did it in my own practice. There are thresholds. There are DSRIP thresholds for the integration of care in terms of numbers of visits. So, for example, if you're a primary care site like an Article 28 facility and you want to add behavioral health, you don't really have to do anything additional licensure-wise until you exceed a certain threshold. And that was a threshold that existed kind of even prior to DSRIP. So if you got more than 10,000 visits or 30% of your volume were mental health in a primary care site, then you needed to go for that licensure. For DSRIP, it allows a threshold up to 49% before having to go for that additional licensure. And it does get fairly complicated fairly quickly. We've laid out a matrix for the PPSs and the providers within those organizations to learn and try to better understand the system, because it is fairly complicated. And it also depends whether you're a mental health site or a substance use site. The regulations are a little stiffer, and there are federal oversight in addition to state regulations, as you probably know, for substance use services. So the question from our dentist colleague here is, how many visits are dental related? We know a lot, and we know that there's an access and capacity issue with dentistry, right? And there are a lot of cases. I know in my own practice this was a huge challenge, that people ended up going a lot to the emergency room and not being able to access dental care. So we know that it is a high cost piece. It is a big driver of cost within Medicaid, of people using kind of the wrong door for that. PPSs are encouraged to include dental providers in their networks, we do. I don't know the number off the top of my head, but I know that it is a significant cost to the Medicaid system for sure. So it's on the radar, and oral health is a component, but it's not a specific project of the menu of 44 projects from which the PPSs could choose. So thanks for your kind attention. I'll turn it back over to Robin.